Good morning, dear friends. As coordinator of the special interest group of the Italian Society of Human Reproduction that deals with the collaboration between the society and other national and international scientific societies, on behalf of all members of the special interest group and of SIRU as a whole, welcome to this meeting. Dear speakers, thank you for sharing your experience on some of the topics that we face every day in infertility diagnostic and treatment. The first topic is hysteroscopy, widely used as a surgical approach for different uterine pathologies. While it is still not accepted by everyone in the diagnostic phase of infertility, in particular as a first-line examination. I think the first speaker will clarify this point. The second topic is about polycystic ovary syndrome and infertility. Polycystic ovary syndrome represents all the time a real challenge with its ovarian systemic and metabolic aspects that lead to great individual variability and that often escapes the even well-defined guidelines. The third topic will consider the impact that pollution, nutrition, and the lifestyle habits have on fertility in different countries and populations. The fourth lecture will consider the quality of the relationships between practitioners and infertile patients, which can generate great trust, but also frequent dropout due to superficiality or lack of clarity and empathy. After this brief introduction, I think we can start with the first speaker, Professor Omar Sefrioui from Morocco. Professor Sefrioui is professor at the University Hassan II of Casablanca, president of the Moroccan Society of Reproductive Medicine, at the same time, president of the Mediterranean Society of the Reproductive Medicine, expert in reproductive medicine and gynecological surgery, director of the ANFA Center in Casablanca, Center for Infertility Treatment, and a very good friend of us. So please, Professor Sefrioui, Omar, I let you the microphone.
Can you hear me?
Yeah, very well.
Well, thank you, Professor Inaudi. First, let me be very grateful and thank the SIG, International SIG of the Italian Society, to invite me, to give me this opportunity to share a very interesting lecture and topic about hysteroscopy prior to IVF and where is the evidence in 2021. Hysteroscopy is a diagnostic procedure, as everybody knows. It's done with the help of an instrument known as the hysteroscope. It's a type of endoscope. The hysteroscopy procedure involves a long hollow tube which has a light source and the camera attached. It's really the checker of the uterine cavity. Hysteroscopy is an important tool on the study of infertility, recurrent miscarriage, or abnormal uterine bleeding, to examine the inside of the uterus and also to diagnose abnormal uterine conditions like internal fibroids, scarring, like ismocele, polyps, or also congenital malformations. Usually we have the rigid and the flexible optic, but most of the practitioners actually use the rigid, especially with the thinner one with the 2.7 millimeters, which can be done in an office without any anesthesia and with a very few discomforts. Let me just show you this first video of the diagnosis hysteroscopy for a patient with recurrent miscarriages, and you see some adenomyosis lesions and also an adhesion on the lateral side, the right lateral side of the uterus. And it took around 30 seconds to do this procedure. To do this hysteroscopy, it's legitimate to ask some questions. In infertility, why prior to IVF? What is the method? What are the indications? And for sure, we need to compare it to other diagnosis methods we have in our hands, and what is the impact of the hysteroscopy prior to IVF. Why prior to IVF? For sure, the data as published by Pendier and El-Touki a few years ago demonstrated that hysteroscopy prior to IVF could be very interesting because we can see around 11% of uterine abnormalities in asymptomatic women in the first cycle, before the first cycle of IVF. Other thing, uterine cavity abnormalities are present in 10 to 15% as a cause of female infertility and can go over than 50% in patients with repeated implantation failure. Hysteroscopic diagnosis and treatment appear to have been very important in patients with infertility or recurrent pregnancy loss. It should be complementary to transvaginal scan and hysterosalpingogram. Diagnostic hysteroscopy is always needed for intrauterine filling defects on hysterosalpingogram. Whenever we found abnormality on HSG, we should do hysteroscopy to confirm or exclude the pathology, to determine the nature of other abnormalities, and to determine the possibilities of endosurgical treatments. But to know what is the impact or the importance of hysteroscopy, it's legitimate to compare it to the other procedures, especially compared to transvaginal ultrasound and hysterosalpingograms. When we compare it to hysterosalpingograms, HSG seems safe, a simple technique for indirect evaluation, and the evaluation of the uterine cavity and fallopian tube seems to be done with a high specificity and sensitivity. For hysteroscopy, it should be adjunct to other procedures, give direct visualization of uterine cavity with cervical canal, and gives also opportunity to treat without any patient discomfort. Hysterosalpingogram, rather disappointing to assess the uterine cavity, and some pathologies can be missed, and the most important of them should be the uterine septum or the subseptum or the arcuate uterus. Endometrial polyps can also be missed. Submucous myomas, especially when they are type 2 or type 3, and Asherman syndromes can also be missed by the hysterosalpingograms. When we compare it to the ultrasound, ultrasound seems to have a predictive value to detect abnormalities from 80 to 100%. But the intrauterine abnormalities seem to be the most difficult to diagnose, especially the malformations and some adhesions or the Asherman syndrome. For the hysteroscope in this kind of lesions, is the gold standard. Uterine subseptum sometimes can be overdiagnosed, and due to inadequate distension of uterine cavity or surgeon's tendency to intervene to achieve a larger and smoother uterine cavity. That's why it's important to know about the reproducibility of the hysteroscopy or the diagnostic hysteroscopy. Casius and co. did a very interesting, published an interesting data and gave the record of hysteroscopy to 4 experts to see if there is any reproducibility. It seems to have a very good intra-observer agreements, so the reproducibility from a record to another seems to be good with the same experts, but between experts there is some less reproducibility, and it can be for the normal cavity around only the 3/4 or 77% of reproducibility between experts, and that can increase, especially with some adhesions and with uterine arcuates. Smith, also in the data published in 2013 in Fertility Sterility, demonstrated that the reproducibility, especially for the shaped uterus or the arcuate, seems very low between an expert to another, and that can probably increase some interventions or some surgeries for the some normal uteruses that can be diagnosed as a shape or a subseptum uterus. We can also ask a question about the endometrial receptivity and is hysteroscopy has any interest. For the leiomyoma, we know that there is it's present into the endometrial cavity, can impede normal implantation. Poor endometrial receptivity of the decidua overlying the myoma, and also there is degeneration with increasing cytokine production that can decrease the implantation rates and also responsible of repeated implantation failure. Endometrial polyps has also some negative impact, and intrauterine abnormalities give also have can have a negative impact with insufficient endometrium to support fetoplacental growth. So most of these pathologies or abnormalities can be diagnosed easily by hysteroscopy, from the congenital one to the acquired one, like endometritis or adenomyosis. But we should know that hysteroscopy for evaluation of the receptivity is not enough. And for that, we need probably to highlight some other procedures like transvaginal ultrasonography, saline infusion sonography, MRI, and also for sometimes endometrial biopsy to evaluate the receptivity assay. But hysteroscopy seems to give us a very good points to evaluate the endometrial receptivity. And we should know that there is no adequate test with 100% sensitivity. For the intrauterine adhesion, hysteroscopy, as I said, seems to be the most important tool to diagnose this kind of abnormality, and any other blind procedure can deteriorate the possibilities for hysteroscopic treatments. For submucous myomas, it can be a reason for infertility or pregnancy loss, abnormal bleeding, defects during hysterosalpingogram, and the diagnosis will disclose the nature and extent of the pathology and the possibilities for endosurgical treatment. The indications in myoma for hysteroscopy is probably done with adequate distension and visualizations, discloses almost every intrauterine abnormality with a high accuracy. It enables also exact localization of the pathology and determination of its intracavitary extent. And for the diagnosis of endometritis and adenomyosis, Unfortunately, conclusive hysteroscope criteria are still lacking. Sometimes, hopefully, rarely, we can also meet this kind of lesions, and a biopsy within hysteroscopy can diagnose an adenocarcinoma. But hopefully, this kind of lesions seem rare. So what are the indications in infertility? Abnormal bleeding, certainly. History of complicated intrauterine procedures or uterine surgery. History of recurrent pregnancy loss. Intrauterine abnormalities on transvaginal scan or hysterosalpingogram, together with laparoscopy, if no hysteroscopy has been done, in unknown or idiopathic infertility, and unsuccessful in vitro and embryo transfer if no hysteroscopy has been performed before. For unexplained infertility, we can also sometimes find some lesions like small endometrial polyps, small adhesions at the corneal cones. And these kind of lesions, even if it's not obvious, but can be responsible of some endometrial dystrophies and may affect receptivity or implantation, especially in IVF. When to do hysteroscopy before any IVF, before the first IVF, or after failed IVF? That is probably the main important question. And the most important one is, should hysteroscopy be performed before the first IVF? Let's see the guidelines. The nice one in 2004 said women should not be offered routine hysteroscopy as part of the initial investigation unless clinically indicated. Effectiveness of surgical treatments of uterine abnormalities on improving clinical pregnancy has not been established. In 2005, ISHRE said hysteroscopy could be useful for infertility investigations, for confirmation of any lesions with other procedures, and for treatment of suspected uterine pathology. In 2011, Royal College said hysteroscopy should not be considered as routine investigation for infertile couples, and ASRM in 2012, hysteroscopy is the definitive method for the diagnosis and treatment of intrauterine pathology. Hysteroscopy should be reserved for further evaluation defined by less invasive methods like salpingogram or sonohysterography. And 10 years later, on 2014, for patients with recurrent IVF failures, a routine hysteroscopy before each new cycle may not make much difference. Routine endometrial scratch would be more beneficial, but the debate is still open for that. But for first-time IVF patients, hysteroscopy still seems sensible. Live birth rates are similar in 700 women data when doing before the first IVF or not doing hysteroscopy. The result seems normal, similar, and not a significant difference. From 2005 and to 2014, we see that ISHRE didn't change the conclusion about hysteroscopy effectiveness. But some contradictions came with some other data. And this one from India, about around 3,000 patients, demonstrated that abnormalities grow or increase from the first IVF to the failure of one or two or more than 2 IVF cycles, and also treatment of these lesions or abnormalities increase the pregnancy rates. Intrauterine pathologies and structural uterine abnormalities that may be responsible for the failure can be detected and treated, resulting in improved pregnancy rates. So hysteroscopy for them is efficient in women with 1 or more prior failed IVF cycle. On 2014, Pundir and Yaqub Khalaf and El-Touki, this is important, but because they made another study 2 years later, in their meta-analysis, they concluded that prior to the first IVF cycle, there was significantly increase in clinical pregnancy rates in the group having hysteroscopy before the first IVF cycle. And they say that hysteroscopy in asymptomatic women prior to their first IVF was found to be associated with improved chance of achieving a pregnancy and live birth rates. This is the other data from Pundir, who went to the same direction and gave us more clinical pregnancy rates after the hysteroscopy before any IVF or before the first IVF cycle in this meta-analysis. And the benefit of hysteroscopy could extend beyond correction of uterine pathology to facilitate transfer and enhance implantation and pregnancy rates. Also, they have made the hypothesis that local endometrial injury can be resulted by hysteroscopy. Then, on 2016, some of the same authors came with a trophy with a multicentric randomized control trial, and they put the question, is it legitimate to do hysteroscopy after 2 or more IVF failures? And what they conclude, that the results were similar in terms of pregnancy rate between patients having or not hysteroscopy. And they asked about the interest of hysteroscopy. Outpatients before IVF hysteroscope with normal transvaginal scan and unsuccessful IVF, for them, does not improve live birth rates. The other data was published on The Lancet in 2016. And the question was, is it necessary or beneficial to do it before any IVF or before the first IVF? And the response was quite clear, because the results were quite similar without any significant difference in terms of live birth rates, because it was similar. And there is no interest to do it before the first IVF. So outpatient hysteroscopy before IVF in women with a normal ultrasound of the uterine cavity and the history of unsuccessful IVF treatment cycles that not improve the live birth rates. Further research are probably warranted, and routine hysteroscopy for them does not improve live birth rates in infertile women with a normal transvaginal scan of the uterine cavity scheduled for the first IVF treatment. We can agree for that. Women with a normal transvaginal ultrasound should not be offered at all routine hysteroscopy. But we can ask some questions. Is it real? Because some other data give paradoxical results, especially the one from Fatemi and the other from Demirol. And they made hysteroscopy for the patient with normal transvaginal scan, and they found that around 10% of patients have, prior to the first IVF treatment, some abnormalities, and this go to 24% when patients have failed IVF cycles. So the defenders of routine systematic hysteroscopy will defend their opinion by saying that imaging modalities do not have high sensitivity. We are talking about the ultrasound in the salpingogram. At least 10% of women suffering infertility has endometrial abnormalities, may be cost effective, and may augment endometrial receptivity. And the others, against, will say that imaging modalities have high specificity. It's an invasive procedure and can give also some complication. So hysteroscopy also could correct endometrial receptivity. This data from both stills for patients with this one is for patient with abnormality, especially with myoma, and they demonstrated that treating the myomas augment or increase the chances of getting pregnant after myomectomy with IVF. Why? Because, as we said, myomas can have give abnormal uterine contractility, some focal endometritis, and a reduced of implantation rates. And these two data demonstrated after resecting fibroid that the results of pregnancy rates seems much better and much higher. This is just a record in our clinic with a bipolar of type 1 myoma. And you see that the procedure is quite simple. And we'll see it's a myoma of 25 millimeters. And this is the result after around 5 to 10 minutes of the procedure. What about the polyps and infertility? We know that polyps can have some negative impact, especially on inflammatory states, was found in polyps among infertile patients, some vascular changes, and also secretion of some cytokines can also alter the implantation rate and the uterine receptivity. So the question is, remove or not to remove any polyp diagnosed by hysteroscopy? The response is certainly not clear, and a majority of the practitioners say that we need to remove polyps larger than 10 to 15 millimeters. This is also a polyp. This is a quicker procedure that can sometimes take 5 to 6 minutes. And you see after the end, after 4 minutes, the result is quite good. What about the septate uterus? We know that this kind of abnormalities, the reproductive outcome is poor, responsible of abortions, premature labor, and also the fetal survival can be affected. Septate may and accurate uterus decrease pregnancy and live birth rates after IVF. But the problem is the results after resection is really not clear. And if the oldest data demonstrated a real interest of resecting septate with improving live birth rates, some other ones, especially this one, this meta-analysis published by Riken in 2020 demonstrated that there was no real interest resecting septum in terms of prognosis for hysteroscopy. And this is also a record in our clinic with a special procedure. This is the thermosection of the septa, and we'll see to go forward. And this is the 3D ultrasound after the resection 1 month later. What about the local endometrial injury? I will go forward for this because there is a lot of debates and a lot of contradictions, and results after scratching endometrial after 2 or more implantation failures are actually not really clear, but it seems to have some benefits to those scratching, especially in patients with high cytokines. We seem to go to this direction. So what about the therapeutic tool? I will go also, these are the first generation of hysteroscopy. And actually we have in our hand new methods that can give probably more comfort to the surgeon. And we can say that hysteroscopy is a very good therapeutic tool. And also we can give us some opportunity to cannulate the fallopian tube in patients with hydrosalpinx also. Some complications around 1 to 2% are to keep in mind, important, especially the perforation of the uterus, but especially in Asherman syndrome or in some not expert hysteroscopists or practitioners. And we can conclude that hysteroscopy allows physicians to diagnose and correct many of uterine cavity disorders. Even if there is lack of consensus to assess hysteroscopy prior IVF, several studies could to show its effectiveness to improve IVF outcomes. And hysteroscopy can also enhance endometrial receptivity, and a hysteroscopy as a therapeutic tool give us a very good comfort with very good results in terms of implantation and live birth rate. And thank you for your attention.
Thank you very much, Professor Sefrioui. Very excellent presentation. We have now a lot of time, maybe for a number of questions. Maybe one question, very short question. If there is a question by someone, no. Just to ask you, you have mentioned just a little about endometritis, which are hot point of discussion, but number of public or paper shown that it is quite important for implantation, and with the frequency in infertile people, infertile women, very high. So in our experience, we find frequently infertility and chronic endometritis, and that become better the situation after antibiotic treatment, especially when plasma cells are positive. So what think about that, and considering that with all other information like imaging or something like that, it is impossible to show the question of endometritis. Only hysteroscopy is a valid tool.
Yeah, I agree with you, Pieraldo. And the problem is multiple, but I will be short. The first one is what are the frequency of these chronic endometritis in patients, in infertile patients, specifically the repeated implantation failure ones. The data are very, very different from one to other. Why? Because the criteria are still lacking, especially for the direct visualization of the cavity. There is sometimes some disappointing criteria, and specifically with adenomyosis. Sometimes it can make some problem to make difference between adenomyosis and endometritis, and we need to do for that. We need to have a biopsy with a bacteriological study, and also the results are not. We need to do sometimes PCR to evaluate the bacteria, the responsible bacteria, and to treat it. So there is probably a lacking criteria diagnosis, and it's still a debatable concern, this kind of pathologies. But we know that there is a benefit to diagnose them and to treat them, because we are sure that it improves implantation and live birth rates for infertile patients.
Thank you, Omar. Maybe we will put together our experience and our results to build a study, if you agree. Okay, I think we can move to the next speaker. Thank you again, Omar. And we move to the next speaker. I let the microphone to Claudio Manna, Professor Manna, that will present and introduce the next speaker. Claudio.
Thank you, Pieraldo, for this webinar, very interesting. And it is with a great pleasure that I introduce Professor Hassan Salam to our webinar. Professor Hassan Salam is a professor of obstetrics and gynecology at the University of Alexandria. He's director many years of an important IVF center. He has a very big experience, and he has been in United Kingdom for many years. And in my opinion, is one of the best person that can tell us, especially on a subject like this, PCOS, that takes into account not only infertility, but the experience, a gynecological experience, very wide, because PCOS is a very frequent condition, is very there are too many types of PCOS. And so please, Hassan, very friend of us, you can start your talk, your presentation.
Thank you very much, Claudio. Professor Manna, I think we will have it recorded, because we are afraid that the internet is not going very well. So I think the technical people are going to run the recording, and then I'll be there for the questions.
Thank you very much, Mr. Chairman. Ladies and gentlemen, I want to start by thanking the organizers of this SIRU webinar, and in particular, Professor Claudio Manna and Professor Pieraldo Einaudi, and also the office and the directors of SIRU, Professors Guillemino and Vigano and Professor Montano. My name is Hassan Salam. I come from Alexandria in Egypt, and today I'm going to talk to you about the prevalence and characteristics of the polycystic ovary syndrome in the Mediterranean area. And let me start by reminding us that this is a syndrome. It is not a disease. And a syndrome is, of course, a set of medical signs and symptoms, because this has a very important implication on our subject today. It is not a disease. It is only a syndrome. The word comes from the Greek word syndromon, which means and many people may not know that the first person who described this syndrome was an Italian person, Dr. Antonio Vallisnieri, who was a student of Marcello Malpighi, who studied in Bologna, Venice, Padua, and Parma, and became the professor in Padua in 1700. In 1721, he described a married woman who was infertile and had shiny ovaries with a white surface and the size of pigeon eggs, so therefore she could only be a polycystic ovary syndrome patient. But of course, the credit goes always to the Americans, and in 1935, Irving Stein and Michael Leventhal produced this seminal paper where they said that they had these patients with 3 big bulbs when they examined them, 2 ovaries and a uterus when they opened their tummy, and then this is how they found the ovaries. And when they did the wedge resection, these women started to have regular cycles, and some of them became pregnant, Stein and Leventhal syndrome. With time, people started to realize that some of these women had also hirsutism, and some of them had acne in their face and other parts of the body. Some other people discovered later that some of these people had insulin resistance. In fact, not all of them, but about 64.4%, according to this paper that De Guardi. More recently, people started to realize that patients with polycystic ovary syndrome had high levels of anti-Mullerian hormone, both in their serum and in their follicular fluids. And so the syndrome became more complicated. It was not only polycystic ovaries, but also high LH over FSH ratio, hyperandrogenemia, increased insulin resistance, increased anti-Mullerian hormone. And these patients, of course, when they are stimulated to produce ovulation, they are very to ovarian hyperstimulation syndrome. And the syndrome has consequences. It has short-term consequences, obesity, infertility, irregular periods, and so on. But more important, it has long-term consequences like diabetes mellitus, endometrial cancer, and cardiovascular. And what is the cause? People have come up with theories. 4 of them are the important theories, as shown here by Crowley, Italia. And in this, and as you probably know,
Yes, please push the video for 2 seconds.
Okay.
And this is the first theory. These are Samuel Yen and Robert Jaffe, as you probably know. Professor Yen, who was the professor in University of California at San Diego, at La Jolla, together with Professor Robert Jaffe, working at the Buffett Hospital at University of California at San Francisco, and produced this very beautiful book, which is still being produced. And in this book, they didn't have a chapter on polycystic ovary syndrome. No, they had a chapter called hypothalamic pituitary dysfunction due to disturbed LH feedback, because they thought that problem is in the LH. The other theory, of course, is the aromatization problem syndrome. And as you can see, if we look at this, this is a follicle here, and inside the follicle we have the granulosa cells, and outside we have the theca cells, and the LH stimulates the theca cells to produce androgens and progesterone, and then aromatization happens inside the follicle with the presence of the aromatase enzyme, which is under control of FSH. As we remember, cholesterol, 27 carbon atoms, goes inside the uterine artery, and there 6 carbon atoms are removed, giving us the group called progestogens, as opposed to androgens and estrogens. So progesterone are 21 carbon atoms. The champion, of course, is progesterone and its cousin pregnenolone, and the difference between them is that the double bond here is starts at number 5, at number 4, and here's number 5. This is why we call this the delta 5 pathway, and this is the delta 4 pathway. They are all 21 carbon molecules, and if we remove these 2 molecules, we end up by the androgens with 19 carbon atoms. As you can see, the androgen androstenediol 2-ol-2-OH, or androstenedione 2 double bond O, 2 ketone, androstenedione. And if we remove the carbon atom number 19, we end up by estrogens, because this molecule has been removed. The estrogens have a nice odor, they have a nice smell, they are aromatic. This is why the enzyme which does this is called the aromatase enzyme. And we owe this work to Professor Kenneth Ryan, who was the professor in Harvard, with whom Professor David Baird used to work when he was young. Of course, Professor Baird became, after that, the professor at Edinburgh. These are the estrogens: estradiol 2-OH, which comes up from the ovary, and estriol 3-OH, which comes from the placenta, and estrone, which comes from under the skin. And if we have a block of this aromatase enzyme, then we have an accumulation of androgens, and this is the second theory explaining why people develop polycystic ovary syndrome. But it is only a theory, as we know. Here is the aromatase block. And this is why in 1990, the National Institutes of Health, 31 institutes with a budget of $30 billion, National Institutes of Health, with one of its institutes, which is the National Institute of Child Health and Human Development, they came up with this consensus in 1990, saying that polycystic ovary syndrome should be diagnosed on the basis of 2 things: oligoovulation and signs of androgen excess. So do they mean that ultrasound evidence of polycystic ovary is not necessary? Yes, they said it is not necessary. But of course, you have to exclude other disorders that can result in menstrual irregularity and hyperandrogenism. But of course, on the other side of the Atlantic, the Europeans were working with ultrasound, and they had seen the ultrasound with abdominal ultrasound and also with vaginal ultrasound, and explained the polycystic ovaries, and also the ovarian volume could be measured by 2D ultrasound, by more recently with 3D and 4D ultrasound. And therefore, to solve this conflict, the ASRM and the ESHRI came together in Rotterdam in 2003 and came up with the Rotterdam criteria, saying what? Saying that polycystic ovary syndrome should be diagnosed on the basis of 2 things, 2 out of 3, oligo or ovulation. The second criteria is biochemical or clinical signs of hyperandrogenism, and this is the biochemical, raised high testosterone, high androstenedione, high androstenedione sulfate, or clinical with acne, hirsutism, or acanthosis nigricans. And the third criterion, of course, polycystic ovaries, meaning more than 12 follicles, 2 to 9 millimeters, or an ovarian volume of more than 10 cc's. But on the other hand, came the Androgen Excess and PCOS Society headed by Ricardo Aziz, and they said, no, we stick to the previous. But of course, they could not deny the presence of polycystic ovaries. But the important thing to remember here is that if you involve the polycystic ovaries in your diagnosis, you will increase the prevalence. So this is why, starting from this point, the prevalence increased from 4 to 6 percent to 21%, as you can see in this study of Italia. So the Society of Obstetrics and Gynecology of Canada came up with a more clear criteria, 2 out of 3, like Eshrey and Rotterdam criteria, after exclusion of congenital adrenal hyperplasia, androgen-secreting tumors, and Cushing's syndrome. The congenital adrenal hyperplasia, of course, or sometimes called the adrenogenital syndrome, is characterized by low plasma cortisol due to lack of 21-hydroxylase or the 11-beta hydroxylase, and leading to the elevation of the plasma 17-alpha-hydroxyprogesterone, which in turn will produce more androgen. The second thing to exclude is the androgen-secreting tumor of the ovary, like the arrhenoblastoma or the Sertoli cell tumor, as you can see here, arising from remnants of the Wolffian duct, leading to androgen secretion in the ovary. And the third thing to exclude is the Cushing syndrome, which is due to hyperactivity of the CRH produced by the hypothalamus gland. So from that time, people started to look at the prevalence of PCOS. And we are told that the total is in the world is about 161 million, because it is 1 in 15 women all over the world, with 29 million in North America, 7.5 in South America, and 19 in Europe, 4.1 in Middle East, 13 in Africa, 89 in Asia, and 700,000 in Australia. But of course, but looking at regional things in the United States, according to these studies, of course, if the studies are done by the National Institute of Health criteria, we will have a lower prevalence. And this is we see here Ricardo Aziz at that time. He talked about 4%. Then he moved to 12%. In the UK, 10%. Southern China, 10%. But in Greece, in the study in Lesbos, in the beautiful island of Lesbos, 6.7. In Spain, and this is in Madrid, 6.5 to 8. And in Turkey, again, it was 6 to 19. Of course, depending on the definition again. And this study from Ding Italia tried to compare between the 3 criteria and find difficulty in putting them. But in general, if we use the NIH criteria, we are between 5 and 7%. If we move to the Rotterdam and to the Androgen Excess Society, then we have in the 12 to 16 range. Another study by Wolf Italia tried to gather information from different studies from China and Mexico and Southeast United States, black and white, and this is how they came up with the result. But what did they say? They said, folks, it seems that there are no racial or ethnic influences on the prevalence of polycystic ovary syndrome. However, we should not jump to conclusion because of biased group selections, small sample size, and then further research needs to be conducted before this generalized statement is accepted. And again, this is the picture which looked like in 2010 with some people, Moran, Italia, saying that, well, it seems that Africa is more obesity, hypertension, hirsutism. North Europe is more hirsutism. India, more of insulin resistance, central obesity, type 2 diabetes, against observing stance, while in Australia, insulin resistance and obesity and hirsutism, and in Mesoamerica, metabolic syndrome, type 2 diabetes, and so on. And one group which started to make sense of all this is the group of Bosdak. What they did is that they did a meta-analysis of the published studies, and they classified them according to the criteria. So if we use the National Institute of Health criteria, then the prevalence in Europe was 5%, Australia 12%, Asia 6%, America 6%, with an average of 6%. But if we use the Rotterdam criteria, then it's more, as I said, because we are using the polycystic ovary syndrome. So in Europe 16, Australia 12, Asia 9, and America 9, with an average of 10. What about the Androgen Excess Society? Now 15% in Europe, 10 in Australia, 8 in Asia, 8 in America, and an average of 10 for the whole studies. And if we look, on the other hand, according to the criteria, if we use the androgen excess, it's 10%, the Rotterdam criteria 9%, and the National Institute of Health 6%. So this is, as I say, if we do not include polycystic ovary syndrome like the original criteria of NIH, we have 6%. If we include them, they are about 10% all over the world. Now, the group of Postdoc Italia also looked at the different criteria, like hirsutism, for example. They found that in Europe, 6 was 14%, Australia 21%, Asia 13%, America 11%, and the rest of the world. So the group, the average is 13% hirsutism. The incidence of hirsutism in polycystic ovary syndrome women. Again, hyperandrogenemia in the blood, 11% in Europe, 7% in Asia, to 18% in America, and for the average is 11%. While if we look at polycystic ovaries by ultrasound, in Europe it was 40%, Australia 38%, Asia 21%, and America 13%, with an average of 28%. Another study which started to look at the national and regional trends is this study by Miaskowski and his and colleagues. What they did is that they looked at the study called the Global Burden of Disease Study. This is a study which was funded by the Bill and Melinda Gates Foundation, and they used the International Classification of Diseases, the ICD-9, ICD-10, where the codes are 28.2 and 256.4. And what they found, if we look at Europe, for example, this study was about Europe. As you can see, in Europe, the highest, the lowest prevalence was in Western Europe, then in Turkey, and in Balkans, then in Turkey, and finally in Russia and East Europe, and the highest more in the rest of the other part of Europe. And what they found is that the highest prevalence in European countries bordering the Mediterranean was in Bosnia and Croatia, and also in Montenegro and Slovenia. And the lowest prevalence was in France. And if you look at the change in prevalence, it was the highest change was in Malta. It diminished by 5.6%, while Turkey increased by 11.3%. So what happened in 2012 to make some sense of this confusion is that the NIH conducted another workshop called the NIH Evidence-Based Methodology Workshop Panel on Polycystic Ovary Syndrome. And what did they say? They said that it seems that we have to rename the disorder completely, or at least to add some phenotypes to make sense of this whole, which was done after that. So now we have 4 phenotypes, phenotype A, B, C, and D. Phenotype A, where we have the 3 criteria together, oligoovariation, androgenism, polycystic ovaries. Phenotype B, where we don't have polycystic ovaries, the so-called the classical, the NIH classification. C is the ovulatory one, because we don't have an ovulation, we have regular cycles. And D is where we don't have hirsutism, we don't have hyperandrogenism, so it is called the non-hyperandrogenic PCOS. So studies started to come on the prevalence of the phenotypes, and as you can see, most of the studies are in North America, in Europe, Western Europe, some in China, some in, but nothing on the southern border of the Mediterranean, in Spain, in Italy, and in Greece, as you can see here. And the other 3 studies coming from the Mediterranean, one from Palermo, one from Sicily, one from Turkey, as you can see here. And as you can see, it seems that phenotype A is the most common one, followed by phenotype C, and then phenotype B, and lastly by phenotype D. And this is the what looks like the Mediterranean. Actually are 20 countries, 10 of them European, the countries which are bordering the Mediterranean Sea, which have a border on the sea. 20, 10 of them European, 8 of them in the MENA region, Middle East and North Africa, and 2 of them an island countries, the island of Cyprus and of Malta. Can we talk about Mediterranean in general? And the short answer is yes, because genetic studies have shown that there is a common genetic heritage which transcends nationality in the Mediterranean people. But this is a subject which I'm not going to go. So if we look about to the prevalence of polycystic ovary syndrome in different parts of the world, if we concentrate on the Mediterranean, we will see that in these 3 studies in Greece, in Lesbos, the prevalence was 6.7, in Spain it was 6.5 to 8, and in Turkey it was 6.1, but of course to 19, but of course it depends on the definition we are using. And one of the important places to do studies is actually the beautiful island of Sicily, because according to genetics, this is a melting pot where most of the people living on the shores of the Mediterranean have been meeting. And one of the important studies have been conducted by this group from Sicily, Enrico Carmina, with Ettore Guastella, together with Professor Rogerio Lobo, of course, from Columbia University, my alma mater, and also with Dr. Mona Nasrallah from Lebanon, looking at the metabolic changes of PCOS women in the Mediterranean. And as you can see from this table, the metabolic changes, of course, in PCOS women are definitely different from those of the controls. Their BMI is higher, obesity is higher, metabolic syndrome, type 2 diabetes, impaired glucose tolerance, low HDL, high triglyceride, and high LDL, all significantly higher prevalence in this group of PCOS compared to the controls. And also they looked at the prevalence of the prevalence of the phenotypes. And as you can see from this table, phenotype A was the most common, followed by phenotype C, which is the ovulatory type of PCOS, and then phenotype B, which is the classical one, the NIH classification, finally by phenotype D, which is the non-hyperandrogenetic, which does not have hirsutism. And as you can see here, if we look at these 2 studies from Italy, both of them from Sicily, we can see that the phenotype A was the most prevalent, around 55%, followed by phenotype C, around 30%, then phenotype B, around 9%, and then finally by phenotype D. And then they looked at different characteristics, like the prevalence of obesity. Now, phenotype B had the highest obesity, 32%, as compared to the other phenotypes. And as you can see here, this is also the altered glucose metabolism. They found that the altered glucose metabolism was more common in the phenotype B, followed by phenotype A, then by C, then by D. And as you can see here, serum lipid values again were more in phenotype B. The total cholesterol, HDL, triglycerides, low density lipoprotein cholesterol, most of the changes were in phenotype B. Lipid alterations, again, as we can see here, is phenotype B, followed generally by A, then by C, then by D. And if we compare this to other studies in the Mediterranean, they seem to be near each other. These are studies from Turkey, from Greece, Croatia, Serbia, Bosnia, and Lebanon, and we seem to have the same results. And in fact, if we look at this study from Bologna and Barcelona and Sicily, again, impaired tolerance is in the range of anything from 10 to 15% by this ROC curve. But the important thing here is what the paper of Carmina Italia said, is that when we compare the results in Sicily with the United States, we found that the incidence of metabolic changes is much less in Sicily compared to the white or the black population of the United States. Metabolic syndrome 6 versus 28, 27 versus 47, total glyceride 3 versus 20, high density lipoprotein cholesterol 17 versus 41. And the cause of this may lie in the diet. In fact, this paper by Orio Italia suggests that this may be the cause, and in fact suggests that it can be a treatment for polycystic ovary syndrome. Looking at hirsutism and hyperandrogenemia, again, as you can see here, in Turkey and Italy, it's from this study from Turkey and the other study from Orio in Italy, it seems that hirsutism is quite high, as you can see here, 100% in this study and 86% this study, as compared to other studies from the UK, from USA, and from Germany. So hirsutism seems to be a characteristic of Mediterranean PCOS patients. And as you can see from this study by Amato, there is a good association between the insulin sensitivity and hirsutism. What about the south border of the Mediterranean? Little is being done. There are some genetic studies done by the group of Ben Salim and his colleagues studying, relating very well the genetics of Tunisia with France. There are two studies from Egypt, few studies from Egypt. This study from Mania showing it's only on PCOS in Egypt. It only compares fertile versus infertile patients, showing that, of course, as expected, the PCOS is more. So in conclusion, ladies and gentlemen, the prevalence of PCOS depends on the criteria used. In Europe, it is 16%, Australia 12%, in Asia 9%, America 8%, with a world average of 10% if we're using the Rotterdam criteria. The prevalence of the Mediterranean is lower. It is 6.8 in Greek study, 6.5 to 8 in Spanish study, and 6 in Turkey. But if you use the Rotterdam, it will be higher. A large study from Sicily showed that the commonest PCOS phenotype in Mediterranean is A, followed by C, followed by B, and then by D, as we said. Mediterranean women with PCOS are less obese than their US counterparts, but more astute than US and European women. In Mediterranean women with PCOS, impaired glucose tolerance is present in 10 to 15%, and type 2 diabetes in 2 to 7%, and this is lower than in the United States. But of course, more studies are needed to define other characteristics, features of PCOS in the Mediterranean region, and I think that we are in a very good position with the Mediterranean Society for Reproductive Medicine, with SIRU, to start thinking about such a study to look at all the 20 countries bordering the Mediterranean. And with this, I come to the end of my presentation, and I would like to thank you very much for your attention.
Thank you very much, Hassan, for this important presentation. You succeeded to give us a very wide perspective of what is happening around the world. But I would like to make you a question, please. We have seen that according to definition, the prevalence can change. But I would like to ask you if you think you have seen in your experience, if in the last decades and with the time, something has changed in the prevalence of PCOS, and if you or the literature can put in a link with the diet that has changed during the last decades, because as we know, we cannot say that a country that is Mediterranean means that the diet is Mediterranean, because we know that even in Mediterranean countries, the diet can be full of, we can say, garbage food. And in this webinar, we are talking just about this. So please, can you tell us something about this subject?
Yes, I think, thank you very much, Claudio, for everything and for the question. I think in my practice around these 30 years, I've seen more of PCOS, but there are many things really to think about. Is it because we are diagnosing it more, because we are using more ultrasound, we are using more vaginal ultrasound, so we can see the polycystic ovaries? And mind you, I've been working in this area for more than 30 years. So at the beginning, there was no ultrasound. In fact, then there was abdominal ultrasound, then there was vaginal ultrasound. This is one thing. The second thing, can we talk about the Mediterranean as a whole? I mean, genetic studies tell us that, yeah, probably Mediterranean people are very much related genetically. But again, it is not the same. And then we have the genetics, and we have the epigenetics, and we have the environmental factors. For example, people in Europe are more conscious about their diet. So they are in the Mediterranean, they probably eat a Mediterranean diet. But in the south of the Mediterranean, the northern border of Africa, for example, I see lots of patients from Libya because they are next to us. And the diet over there has changed very much along the past 30 years. And then, as you probably know, there is a very high incidence of diabetes and the metabolic syndrome. And we see many polycystic ovaries also. Are they related? Which one is first? Is the diabetic diabetes bring the syndrome, or is the other way around? So really, it is it is very difficult to answer the question. And I think this is what I meant at the end of my talk. I think with Mediterranean Society and with SIRU, we can conduct such a study, because I have been looking at the subject since you gave me this subject to talk about. There is very little information really, and the information is haphazard. Some people use the NIS definition, some people use the Rotterdam definition, some people, the Americans, always like to stick with Ricardo Aziz about the Androgen Access Society. So we really need more studies. And I mean, we are 20 countries in the Mediterranean, including I mean, Italy, of course, is a very important country, as I said. And then if we can have like 200 patients from each country, I think we can cover this. I mean, we will have 4,000 patients. It will be a large study, and we will have good answers for the Mediterranean as a whole, and also for each country. So the short answer is yes, I think it has been increasing, at least in my part of the world. Yeah.
Thank you. Thank you very much, Hassan.
Sorry, can I just stop you 1 minute? Because we have a big delay. So I would like to ask also to have a very, very short question and very brief answer. But I would like to propose also, because Professor Montano is not present, but he sent to us a recorded speech. And I would like to propose to change and to give the possibility to Dr. Artusio to speak now before Montano, if she agree, and we can launch the talk of Dr. Artusio. Dr. Artusio is here, is with us. Do you agree?
Yes.
To anticipate your talk?
Yes, of course, it's a pleasure.
Just a brief introduction. Laura Artusio is a psychologist and research fellow at the University of Florence, where she directs the Laboratory of Psychology, Emotion and Research, named Per Lab. Founded in 2013 during her European PhD, she was working in collaboration with the team of Yale at the Yale Center for Emotional Intelligence since 2009, and her goal is to bring emotional intelligence evidence program in workplaces, fair work approach, and in the school system by ruler approach. Besides doing research, she has trained thousands of people from different organizations around the world on emotional intelligence and work-related stress. Thank you, Dr. Artuzio, and you have the microphone, please.
Thank you, Professor Einaudi. Thank you, everybody, for the opportunity. It's a great honor to be part of this interesting webinar and offer a contribute to this interesting field of research. As you mentioned, I'm a psychologist, and I'm lucky enough to be part of a team of researchers, mainly psychologists, methodologists.
Presentazione, dottoressa.
Sì. Can you see my slide?
Okay, thank you.
Yes. So thank you to PERLab team to support our work in Italy and Europe. We are researchers and consulting in field of emotional intelligence and work-related stress. And we are honored to be partner of the author who started this field of research. So Professor Peter Salovey is the 23rd president of Yale University nowadays, but in 1990, he was the author who first formally defined the concept of emotional intelligence together with his friend and colleague, Professor Jacques Meyer. In the 80s, there was a kind of interest in emotion and cognition, but when they developed the concept of emotional intelligence, this was not that interesting at that time. It was mainly considered like an oxymoron, like a contrasting concept, or you are intelligent or you are emotional. But actually, like neuroscientists such as Antonio Damasio supported then the idea that you need emotions to properly think and behave, to make effective decision. And so they basically were a friend, and they were painting. This is a nice story. They were painting home, discussing about how weird was the fact that researchers who were doing research on intelligence were very separated from those who were doing research on emotions. And so they didn't want to invent something new, but just create order in the scientific literature, defining the concept on emotional intelligence. Which is grounded in the Howard Gardner multiple intelligence concept. And one day they were painting home and discussing about research, conferences, and the mother of Professor Meyer went back home very disappointed by her doctor. And she say, I don't care if he's the most famous doctor in the world. For me, he's not a good doctor if he doesn't take in consideration my emotions. And this was a kind of inspiration for them to define this concept. And so I wanted to share this story because everything started thinking about the healthcare system in first. Now, the majority of people know the concept of emotional intelligence thanks to Dr. Goleman, who is a journalist who spread the concept of emotional intelligence, but I would say not in a scientific way. So he joined the seminar of Professor Peter Salovey and Jacques Meyer, and he was writing a book on empathy, and he decided to change his title of his book and to focus on emotional intelligence with the intuition that was a very innovative concept. But the good thing is that made emotional intelligence popular. The bad thing was that was not that scientific and created a kind of confusion in our field of research. So just to clarify the theoretical background that we propose. So this is the definition of emotional intelligence. It's an intelligence which refers to emotions in ourselves and in others, and is defined by 5 specific skills. Skills that we can measure and develop. The first one is the skill to perceive emotion. Is the skill to perceive emotion in ourselves and in others. For instance, a doctor who is going to communicate bad news to a patient. This is a very common topic in this field. Is it important that he is able to perceive his own emotion, but also the other person's emotion? So maybe he's feeling stressed because it was a tough day. He's going to communicate bad news. And it's important to be aware of his stress or his sadness, because this is going to impact the communication. But at the same time, it's important to perceive emotions in the patient in front of him, not just to watch, but to really look the cues of the facial expression, of the tone of voice, the posture, the body language, because sometimes patients are not that good to express verbally how they are feeling. Maybe they are foreign or they don't have the words to describe. So it's very important to perceive this information. The second skill of emotional intelligence is the skill to understand emotion. It's the head of our dragonfly, because it's really the skill to think about emotions, including complex emotions, complex feeling, to understand causes and consequences. Am I stressed because of the work that I did this morning, or the call that I just had, or because the person that I have in front of me? It's very important to be able to identify the causes of our emotions, but also other people's emotions. So maybe I perceive that the patient is feeling desperation. Am I able to understand the causes and the possible consequences? The third skill is the skill of appropriate expressing emotions. It means according to my role, the context, the cultural behavior, my behavior could be misunderstood or could be offensive. We send messages with our faces, with our tone of voice, and there are people who are more skilled or less to properly express emotions. What if a doctor who is communicating bad news is showing contempt with his face, or maybe is showing a more trustable emotion, completely change the relationship. The fourth skill of emotional intelligence is the skill to regulate emotion, to manage emotions in ourselves and in others. We focus on these skills, especially during our workshops, and we work on strategies. Could be like health habits, food, sleep, exercise, mental strategy like positive self-talk, positive reappraisal. Could be social strategies like social support, asking support to a professional. This is very important that healthcare professionals can have effective strategies for themselves to protect their health, but also to propose patients. In our example, could be to offer strategies to the patients carrying bad news to handle this desperate moment in an effective way. The using skills, the fifth one, the last one, is the skill to use the power of emotions to facilitate thinking and behavior. It means that there are not positive or negative emotions. All emotions have costs and benefits, but we can make a bad use or a positive use of emotions. And also sadness and desperation can help us to grow, to build resilience. And this is how skilled people use emotions to grow. And to build trust is the skill to generate emotion in person to build trust. And this is so important for healthcare professional being able to build that trust. So this is just to show the theoretical background. So it's the ability model. We know that the ability of EI, of emotional intelligence, are critical and impact more or less the 25% of our behavior, but they don't explain the whole behavior. There is genetics, there are other variables such as personal traits, other variables, but 25% it's a lot. And it's fascinating that we can develop emotional intelligence skills. We can do something to make this higher. And why we should develop emotional intelligence is because this is related with performance, with psychophysical well-being, with effective decision-making, effective judgment, problem-solving, leadership, higher interpersonal relationships quality. We know that increasing emotional intelligence, we decrease stress and burnout. This is our main focus of research and work. So we reduce the risk of mistakes, errors, conflicts, the risk to develop anxiety and depression disorder, to use substances, which is very big deal also in healthcare professionals, work harassment and aggressiveness. So according to the scientific literature, those are the main outcomes that we can expect enhancing emotional intelligence skills. And so in the last 10 years, we have been trained really thousands of people from healthcare, but also other sectors. And sometimes when you speak about emotional intelligence, people define this like a soft skill, which is not. It's not a soft skill, it's an hard skill. And we work a lot, for instance, is managing emotions in emergency situations. Let's think about panic or what we lived with the COVID pandemic. So it's not just to be kind, it's not a personality trait, it's the skill to recognize, understand, express, manage, and use emotions to survive, to create trust, to create relationship, to protect our health. So the safety in workplaces offer us a hard skill pattern to propose protocol, to propose workshops, but also to collect data. And this is what we have been doing in the last 10 years, collecting data, especially in work-related stress. In Europe, it's mandatory for organizations to assess work-related stress. And this is a huge opportunity, we think, because let us work with hospitals and organizations with a meeting every 2 years. Every 2 years, the organizations need to update the work-related stress assessment. And in these 2 years, they are supposed to do training, to do support, like coaching initiative to handle healthcare, for instance, professionals' well-being. And according to us, this is the first step, to work with, to help a professional of the healthcare sector to protect their well-being, because the risk of burnout, which is an emotional stress typical of psychologists, doctors, who maybe were very motivated at the beginning of their career, but then this emotional labor, the pain, the death that maybe they cope with every day can really risking to burn out. And so this is something we can do. We validated a questionnaire, which is WOSEC, Work-Related Stress and Emotion Questionnaire, which include work-related stress measure, but also emotional climate. And this is with the new scale, also with the COVID risks, which are techno-stress, COVID, the smart working, forced smart working, and the risk to get COVID. And our goal, our next goal of research is to create a version of WOSEC specific for the healthcare version, because it's important to have a specific scale for a specific sector. So this would be a line of research we think useful to create protocol, to have a process when we can have data, intervention, verify the effectiveness of the intervention, and then again data in an endless process like it should be. starting first with the well-being of healthcare professional, and then this will impact the relationship with patients, because sometimes a burnout healthcare professional is detached, is not empathic, because it's if you don't train effective strategies to handle your emotion, you will defend yourself how you can, maybe becoming too detached, which is typical of burnout. I don't want to abuse of the time available. I just want to leave you with the words of the Afro-American poets Maya Angelou, which are: people will forget what you say, will forget what you did, but people will never forget how you made them feel, which is so true also in the relationship with patients in the healthcare system. So thank you for your time. I'm very happy to answer your question.
Thank you, Laura, for your emotional talk, I would say. People that followed your talk. I think that you touch an argument that is all the time present in our work, in our relationship with our patients. In infertility, there are a lot of hopefully good news and a lot of, I say, it's not bad news, but you say not good, not bad, but sometimes we are in difficulty emotionally, I would say. So I asked in my mind if your questionnaire could be useful for our world, our reproductive context, and if the questionnaire could be administered to our practitioners, maybe in different countries, or if there is an interest in knowing this context from the managing of the emotions. What do you think?
Thank you. Of course, yes, I'm more than happy to offer the questionnaire also for research or intervention, and absolutely I think could be very helpful. Nowadays we have the general version for workplaces. Would be interesting to adapt this to the healthcare sector, but also the general version is very useful and in two levels, I think. So the first is for the healthcare professionals in terms of organization. So for instance, the hospital, the organization could assess work-related stress and emotional climate as to protect the healthcare of professionals. The second level could be in the couple. So to work on stress, to measure stress also individually, because sometimes stress can impact also the fertility process, and it could be useful, I think, to assess work-related stress. Could be emotional intelligence included, could be a new line also of investigation and intervention. So in those two levels for healthcare professionals, well-being, and the second level is in the couple. So to work on stress, to provide strategies. Sometimes we have vicious cycle, you know, maybe you are stressed, you are disappointed, and you are even more stressed and anxious, and this doesn't help the couple. And being able to offer concrete evidence-based strategies to handle with these can be very useful, I think, yes.
Yeah, thank you. Because I think that we have a high level of dropout by the patients. So I was asking myself if this could be a reason for this kind of dropout. Is Stefano Bernardi with us? Stefano, are you here?
Yes, I am here. So thank you, Laura, for your relation. I have a question for you. I have a question for you. You think you talk about the emotion, no? And I think the emotion are very important for our relation. But I think also the empathy. What do you think about empathy in the relation doctors and the patients? Because when you talk about bad news, I think the empathy, no, is a big, important factor for the doctor. And we are psychologists, and psychologists habituated about the emotion, but the doctor saying the emotion is no is not the same. Is not the same. So, what do you think about the role of the empathy?
Yes, I have to say no, doctor. Thanks God, there is you can find also doctor very good in this part of emotions. And yes, empathy and emotional intelligence, let's say, are cousins, so are separated concept, because in research in psychologists you need to be very coherent with the model. So if we are measuring emotional intelligence, we are measuring something different from empathy, but there are some overlapping. So in empathy, you mean the skill to recognize emotions in the other person, to understand emotion, keeping your identity, we could say, to put in the other person's shoes, and sometimes could be more a cognitive empathy, where you understand what the other person is feeling, but you are not really emotionally connected, like I feel what you feel. This second scenario is more like emotional empathy, where you are really emotionally. And let's think about a doctor, a nursing in a hospital. You cannot be all the time emotionally connected, because this is going to be too much, and you are going to perform even in a worse way. So it's not a good idea. But sometimes you need to have cognitive empathy, sometimes emotional empathy, but are a close concept with emotional intelligence, but it's not the same. In emotional intelligence, you have also the strategic area, where you manage emotions, not just understand, recognize, but also you handle, you manage, you have strategies to handle your and other person's emotion. You use emotions to facilitate thinking and behavior. So it's also more in action, I would say, and it's a more complex concept. It's an intelligence, like I mentioned Gardner with multiple intelligences. It's more complex, but it's close to empathy. It's very important now, empathy too.
Thank you.
I'm sorry, we have a very big delay. So if you agree, we have more time at the end of the next speech, we can continue till the end of the connection time. It will be a great pleasure. My co-chairman is here, he's there.
Thank you.
Claudio, thank you very much.
I am here, Piero, yes.
You can go ahead and go ahead with the last presentation and last speaker, which is not here in person, but
yes,
which is recorded the speech.
Okay. Luigi Montano is an andrologist and one of the leader of SIRU. Let's say that he became famous, let's say, like this, because of his studies on environment and its influence on seminal fluid on spermatozoa. Not only for spermatozoa, but as a tool to investigate the health of the people. So please, we can go to his presentation and then after make some comment on that.
Dear colleagues, I'm sorry not to be with you for family reasons. I leave you my lecture, and a special thanks to Professor Renaudi for having organized this interesting webinar on such important topics. I'm sure that at the end of this webinar, we will all take home useful new information which enriches our wealth of knowledge. Let me do a short introduction. I will talk you how chemical and physical pollutants, in addition to bad lifestyles, represent the most important threat to public health, and the dramatic decline of fertility, especially male, not only in Western countries, represents the most faithful and best measurable mirror of the consequence that human activities have long been having on the planet. Pollution is widespread, it's true, but there are areas of the same country or same region in all world with high environmental impact and with health criticalities. And I will focus on a project born from one of these areas, land of fires in Campania region, southern Italy, with high environment impact. And this project embraces all the aspects of the title of my lecture: environment, lifestyle, and diet. Well, now I start with my presentation. And in this first slide, you can see how it all is interconnected and how the planet health is suffering. So we identified a lot of reproductive hazards, metals, pesticides, and other compounds. All of these substances are endocrine disruptor chemicals. The definition is an exogenous substance or mixture that alters functions of the endocrine system and consequently causes adverse effects in an intact organism or its progeny or subpopulation. And you can see in the image how these substances are in all our body fluids. Here you see how these substances interference with hormones, enzymes, and other metabolic pathways. And obviously, it leads to metabolic dysfunction. The target of endocrine disruptor chemicals are on wildlife, decline of some species, for example, sterility in American alligator, or change of sex in fish and shellfish, and other fertility problems in wildlife. But in human health, we see increase of non-communicable diseases as cancer, diabetes, obesity, endometriosis, early puberty, heart diseases, and infertility. These chemicals are antiandrogenic effect or estrogenic action. And you see reduction of testis volume, low semen quality, reduced anogenital distance, and greater sperm and reduced penis length. Radiation for have a lot of great impact on male fertility. In fact, electromagnetic fields have deleterious effects on sperm parameters, sperm count, morphology, motility. In fact, they induce oxidative stress with increased level of reactive oxygen species, which may lead to infertility. And the review concluded that radiation have negative effect on sperm quality. Also, lifestyle have a great impact on fertility. In fact, they have a lot of consequence on fertility. Obesity, heavy exogenous nicotine addiction, smoking, and other bad lifestyles have impact on fertility. Obviously, low physical activity and junk food have bad impact on fertility. All this has led to decline of fertility, male fertility. In fact, you see in this image how the decline can consider as human semen as the most faithful mirror of lifestyle and environment change in the last 70 years in Western countries. But the consequences are also in other countries. You see the data of Africa, but also in China, India, sperm concentration here motility, morphology, all parameters are in decline. So a lot of epidemiological and toxicological data show how the male reproductive system is particularly sensitive to the pollution, and male reproductive system can be considered a sentinel organ, and the dual function of human semen as environment and health marker has good support from the scientific literature. In particular, human semen, for example, is a good environment marker. Why? Epidemiological studies on humans and toxicological studies in animal models show how some of the major environment organic and inorganic contaminants reduce seminal quality. A lot of spermatogenesis, like oogenesis, for example, from puberty onward, is continuously and therefore more easily exposed to insults in a stage of continuous replication, and so male germline accumulates mutation faster than the female one. The mechanism through which contaminants exert their action, probably working in combination, are genetic, epigenetic, and hormonal imbalance, oxidative stress induction, for example. Sperm cells are more susceptible than eggs to the effects of oxidative damage because they lack significant antioxidant protection because of reductive cytoplasmic space for an appropriate armory of defensive enzymes and significant amount of polyunsaturated fatty acids. As health marker, recent studies showing a relationship between male infertility, chronic diseases, comorbidities, and even mortality indicate semen quality, an important indicator of general health. In this work, I've described the role of human semen as an early and reliable tool of environment impact assessment on human health. And human semen can be an environment marker, and it could be a powerful tool for public health. This publication is in 218. In this and in other, for example, this in 2020, I have make another review on reproductive biomarkers as an early indication for assessing environmental health risk. In fact, in this prospective fertility assessment may be an indicator of overall health, and the attention on maximum fertility age can be important for chronic disease prevention. And the potential preventive and predictive role of reproductive biomarkers for chronic adult degenerative disease is important. Now we have a great interest of transgenerational effects induced by pollution and lifestyle to epigenetic modification on gametes shift the interest of prevention as far as preconception, and therefore the interest towards reproductive system and biomarkers assumes a greater significance for safeguard the health of future communities. Regarding communities, this is the Italian study on environment high impact areas of Italy, contaminated sites, where in this report was seen that cancer risk in polluted areas is 9% in age 9 and 24 years. In particular, the excess of incidence for leukemia and lymphoma non-Hodgkin is about 50%. In this slide, you can see many polluted areas in Italy. We start from this area. For example, land of fires in red. We start from this area in southern Italy, is famed for a lot of source of pollution, illegal disposal and urban toxins and industrial wastes, dumping practices, traffic, intensive agriculture. Is a great and widespread area, and we have verified biohazard index to checking the status of contaminants bioaccumulation and biomarkers of effect and susceptibility in homogeneous samples of the population living in two areas with different environment pressure index. And this project was considered the first biomonitoring study in environment impact or polluted areas of Italy. Is a human biomonitoring study with omics multidisciplinary approaches involving environment, lifestyle, and diet, using the qualitative and quantitative chains of human semen as a key to understand both the level of environment quality and its long-term modifications to set out health risks for population in relation with their living environment as well as diet and lifestyle. The aims are developing a better understanding of the effects of environment pollutants on human semen parameters, evaluating qualitative profiles and bioaccumulation in homogeneous subjects living in areas with different environment pressures, identifying early and sensitive semen biomarkers of toxic bioaccumulation, qualifying human semen as an early and sensitive environment and health marker, proposing human seminal model for early detection and prevention of environment health risks useful for innovative programs on health surveillance, identifying lifestyle and especially dietary approaches with anti-inflammatory, antioxidant, and detoxifying properties may be effective in mitigating and reducing environment impact on human health, improving human semen quality in men living in polluted areas. The project has a primary and pre-primary prevention and is divided into steps. First step, first sign of damage from environment pollution on human health, considering human semen sentinel of environment and general health. And second step was to verify how Mediterranean diet or other nutraceutical substances can detoxify the organism. And we have called natural remediation of polluted melt. Here you can see the recruitment areas, the selection criteria, and the exams performed on different matrices, especially on semen. As you can see, there are different analyses on different matrices starting from the seminal fluid. On the other hand, the second step is an intervention to evaluate which of these three dietary regimes manages to reduce the rate of bioaccumulation of pollutants. For the intervention, we considered at least 3 months in relation to the cycle of spermatogenesis. This slide takes up the previous concepts for the human semen as a sensor of environment quality. This Campania region in, excuse me, one moment. Here, this Campania region where we have conducted the first biomonitoring study in 2 areas with different environmental impact. And one, land of fires in red, and Alto Medio Sele in province of Salerno in blue. This is the municipality. The male were healthy male volunteers in fertile age, 18 to 30 years old, residents for at least 10 years in the study areas, no chronic diseases, no varicocele, no drinker, no smoker, no reported history of drug abuse, body mass index, waist circumference of 102 centimeters, no azoospermic or cryptospermic. This is the first publication in, I don't remember, and in 2016, and this is the first study where we have recruited about 200 healthy male in 2 areas of Campania region. We see a lot of differences between males of land of fires and males of Alto Medio Sele, with excess of metals in blood and human semen in aluminium, chromium, and other metals that you see. Also sperm quality, high DNA sperm damage, and low antioxidant enzymes. Here you can see in more detail important differences for antioxidant enzymes, DNA fragmentation index, and total antioxidant capacity in semen, not in blood. Here again, differences in length of telomeres in sperms and not in leukocytes. The highlights of these 2 works published on 200 boys of homogeneous age and lifestyle in these two areas of Campania region indicate trace elements in semen and blood, discriminate people living in polluted areas. Seminal plasma is more sensitive than blood to redox status alteration. Lower sperm quality and antioxidant defenses associated to highly polluted area. In healthy males, semen is proposed as early biomarkers of environment pollution. Taken together, the sperm and redox findings indicate a possible pattern of early semen biomarker for healthy adult males living in the land of fires, eventually transferable to other pollution scenarios. This is another publication that reports the presence of ultrafine atmospheric particulate in the human semen found with the special electron microscope to evaluate how much what we breathe enters in our body. This is a summary of a published work where we report how semen redox status, motility, DNA fragmentation index, and sperm telomere length can be considered as early markers of environment pollution, and human semen seems an early and sensitive source of biomarkers than blood to monitor high environment pressure on human health, hence useful for innovative prevention programs and health surveillance in risk areas. Here is a work in which we defined how the first parameter that is affected by atmospheric pollution is the DNA sperm DNA. And in this work, published in 2020, we again report differences between boys of land of fires in the study of protamines histone ratio, where we found 84% of those males and a different DNA binding. Furthermore, we also discover how nuclear proteins are altered by pollutants and how they cause damage to sperm DNA. In this work, published on environment pollution, on volatile organic compound in blood, urine, and human semen, we found how human semen showed to be a good biological fluid for pollutant exposure evaluation for this compound, how the amount of compound was found much more evident in human semen respect blood and urine. On the basis of this publication in Campania region, the project has expanded to other areas of Italy. And we have built a network of the project. So the Ministry of Health funded a part of eco-food fertility project in some highly polluted areas of Italy. At the moment, the projects are going also in Spain, and the Italian network also is concentrated on follicular fluid with the same study design of eco-food fertility. This is the network and researcher of eco-food fertility project. And this is the project founded by Ministry of Health, published in February of this year on European urology focus. The project was conducted on about 350 healthy young males aged between 18 and 22 years, non-smokers, non-drinkers, no professional exposed, and homogeneous for body mass indices of 3 high pollution areas of Italy: Brescia-Caffaro in North Italy, Valle del Sacco in central Italy, and Land of Fires in South Italy. The project leave an important result. The project was divided in 2 steps. One for evaluation of fertility and levels of environment toxicants in blood and human semen. And second step, according to a randomized clinical trial, to evaluate the effects of diet, Mediterranean diet, and physical activity on fertility and contamination. The subjects of the trial, intervention and control, had homogeneous anthropometric and seminal parameters. But the seminal parameters were statistically significant among between the boys of the 3 areas. You can see here the p-value and the difference between 3 areas: boys of Brescia, boys of Land of Fires, boys of Sacco rivers. The results of the intervention reported significant improvements of all seminal parameters for the intervention group in 4 months of intervention. You see sperm concentration, total motility, progressive motility, cell with normal morphology, and concentration of round cells. The percentage of boys with improvement in seminal parameters is significant in 2 times among those who performed the intervention. Adherence to the Mediterranean diet was also significant for the intervention group compared to the control group, but the antioxidant capacity in the semen was less improved, how you see. In this slide, you can see the contaminants in healthy young males of the 3 polluted areas, where you can see the differences in the 3 groups of pollutants. It is in close relation to the environment in which they reside. In conclusion, study results showed that an intervention based on Mediterranean diet and regular physical activity lead on improvement of semen quality in healthy young men. To our knowledge, our study is the first randomized controlled trial to evaluate the effects of a dietary and physical activity intervention on semen quality of healthy young men in polluted areas. In the future, we have to develop other project lines that you see listed here. And for this, we are in contact with other centers in Europe. This just published opens the way to the study of early biomarkers of effect on the female side, and this also represents a new challenge to complete the project. In conclusion, with a strong focus on the future of communities, male reproductive system represents a sentinel organ. 2. Biomarkers of reproductive health should be exploited as early signals of environment pressure, and increased risk of adverse chronic health effects, so that the use of human seminal model might be the main objective to be considered in the agenda of public prevention policies for early detection and innovative programs of health surveillance in environment risk areas. So all operators of human reproduction must consider a new role of fertility, such as basis of primary prevention, not only for reproductive diseases, but also for chronic diseases of present and future generations, projecting fertility into a wider dimension for the protection of public health. Thanks for all.
Thank you very much. I think that as Luigi unfortunately is not with us, maybe it's not considering also the delay we are. If Piero is agrees, no question I think are admitted at the moment.
Maybe if our discussants have a very short question for the other speakers, eventually we can accept 1 or 2 minutes, and then I let the microphone to Dr. Lepadato for conclusion and myself for thinking.
So we are very late, so we quickly. I want to thank the speaker for their interesting relation. Your word and experience are stimulating me many thoughts. When I see the program, I thought it's very difficult to find harmony between the various topics, but I think the only way is to remove the separation between mind, body, and environment. I think about integrative medicine, in which the body and mind are placed in a relationship, and toward this third agent, I think about environment. What emerged from this new approach is need to interdisciplinary work. So I think after the relation for Laura about the mind, where is the mind? The mind is only in the head? No, I think no. I think the mind is in the head is the first brain, and the second brain is the enteric nervous system, and the third brain is the cardiac system. So Laura thought interesting the relation about Laura, because the emotion are important. Emotion are important role in the people. Sorry. I want to speak slowly, but the word is locked. The emotions play a fundamental role. Emotions such as anger, joy, frustration they allow action and they symbolize the experience. The emotions are mental and physiological. Emotions are chemical, or rather, emotions are a chemical response. Emotions are three functions. They control the physical environment, they control the internal environment, and the social. Is the problem, no, for the Laura look the attention about the doctor about use the emotion, and I think that for the doctor is a little problem, because not only work about with the emotion of the patient, but work also with the emotion of himself. So when the patient come back in the center, no, bring the emotion, bring the request, no, I want a child, and the doctor have a bigger response about it, no, I do it. So when he have this important goal, many emotions from both working in this relation. There are dynamic, dynamic that including not so for the people or the patient, but including the doctor, including the mind, including the body, and including the environment. Look at the stress, The stress is an example. Look at what Laura said about bad news. What I think about it, I think it is need change the view. The view is a biopsychosocial approach. If I use the biopsychosocial approach, I can take care of the patient in all the dimensions, not only the symptom about the problem. So I just want to put my attention in one way. When I meet the people, I meet the people with the problem, but I meet the people with a history. I meet the people with a emotion. I meet the people with a expectative. When in this webinar, want to do this message, change the mind. The mind is biopsychosocial vision, not only a part of the man, a part of the patient. This is my thought.
Thank you very much, Stefano. And Claudio, if you agree, I let the microphone to Dr. Lepadatu for a final. I think that there would be an enormous amount of question and discussion and so on. So I invite you all to be part of our National Congress in October, to continue and to be practical and pragmatic, to put some project on the table, multidisciplinary, multi-internationally, and so on. So this could be just a drop to continue to discuss and to develop a project. So please, you agree, and
yes,
Claudio?
absolutely. I agree with you.
We are very late.
Yes,
Please,
I have just few words to spend to conclude. I like to express my whole gratitude to the organizers and to the special, let's say the very special guests that gathered here today to focus on the common denominator of the infertility problem of our Mediterranean cradle of civilization. Don't forget it. This is a cradle of civilization, the Mediterranean one. So our cradle of civilization has a problem of infertility, an important one. This is the disruption. So the cause of this infertility is a disruption, as our colleague says in some of our presentation. And we need a lot of humble to define infertility like the major disruption of the environments. We talk about the disruption of the uterine environment with Professor Sefri. The uterus is an environment, very important one. The lifestyle with the stress, very disrupted. The endocrine environment, and Professor Salam talks a lot about PCOS, the food disruption, and the emotional distress too, with Laura Artuzio. So it's all about disruption, because when we talk about the endocrine disruptions, we don't see a PCO fat with a lot of hair, is a lean PCO patient also. So there are the disruption, the extremities, the too much or too less. We have to refill these containers that remain empty because of these disruptions. And this is the perfect place or container where to put the things that we let out, the people, the couples, the emotions, to focus again, because we are out of focus. I remember in the last ESHRE in presence in 2019, one of the activists that speak about the infertility that is asking, "Doctor, are you hear me?" So we have to turn to hear our patients. What are asking for is not only the baby. They are asking to feel good. They are asking to be together. They are asking to tolerate, just tolerate. I saw a couple today, and I like to being thankful to Stefano, because he reminds the emotions. The couple came in, and I asked if they are looking for have babies, and what's the problem? No, we are not looking for babies. We are looking for information, and emotionally speaking, we don't tolerate this situation. And my answer is, oh, nice, this visit is very quick. We have a very good psychologist for you, so thank you to express immediately your asking. What is your first interest? Because I was going to lose my whole time speaking about doctors, about medicines, about the sexual cells and so on. They are just about to tolerate this terrible situation in which they were in that moment. So very grateful to have the opportunity to give to spend some few words about, to remember that the infertility is disruption. Then make something fertility is like give a planter to a plant, and the webinars and the Congress and the meeting like this is a planter for our plants that we are going to make grow with such cure. We know a lot. So the problem is not cure. We are very good to cure. And this is in respect of the SIRU spirit, putting together a lot of disciplines of a lot of people with a lot of culture or point of views, and make fertility human again. It's not like an American say, but make fertility human again, because I'm working about heterologous reproduction. It's not a cure, it's a prosthesis. And that work is about tolerate a prosthesis. It's about Pistorius. It's not Paralympics. It's accept a prosthesis and understand that it's just a prosthesis and not a cure. Thank you so much. It's a very, very nice evening with a lot of spots and a lot of stimulus for us together. Thank you so much.
Thank you very much, Corina. I think we will spend some time to discuss about all the arguments that you have presented now. Maybe I repeat it again in October at the Congress. I stimulate all the people today that take part to this webinar to meet in person, because we have to continue to discuss in this way. I would like to make the conclusion, if you agree, Claudio, or you have something to say again?
Oh, I think that you told us what you had. Everybody gave the contribution, a very important contribution, and
Yeah.
we must continue. You said well.
Okay. I would like to say thanks to all the foreign friends, because I know that there are some members of other society which are connected with us. And to the speakers, Hassan, are you always here? Thank you for your presence. Thank you to be part of our webinar and to be friend of us since many years. So thank you to my co-chairman.
Thank you,
And,
Piero. Thank you for having invited me to co-chair you.
It's a great pleasure, you know. To the discussant, thank you, Stefano. But I would like to do a special thanks to special people. Never happened without them, and are the technician permits our in a simple way apparently the connection, and to a very special person, which is Carlotta Persano, which is the director of the organizational office of SIRU. Particular thank Carlotta by all the speakers.
Thank you.
That are connected with us. And what else to say? Nothing. See you to the next time, maybe in person. Thank you.
We hope. Thank you.
Ciao.